afternoon. It's actually noontime right now. It's 12 something in the afternoon, and I'm still off today. So I was kind of thinking about, why not do some vlogs today? Just didn't everything shower because I feel like I needed to. We're gonna talk about the typical what do you call this? The typical routine of a Medsurg nurse. So I'm gonna talk about our daily flow as a Medsurg nurse, since I've been working as a Medsurg nurse for I think more than 8 months now. So I'm going to talk to you about what it is typically that we do as a Medsurg nurse. So basically our flow, and I'm working as a day shift nurse. I will only talk about how the routine for us day shift Medsurg nurses. I think it varies on which area you're working to. It doesn't mean that I'm talking to you guys about this. It's gonna be the same thing as all the Medsurg nurses. So this is just based on my experience, basically. So first thing is I think I've already, in my previous vlog, I was talking about pre-shift anxiety, or how to manage pre-shift anxiety. So usually I wake up very early in the morning, 4:30ish, get ready, leave the house around 10 minutes before 6 o'clock so I can be at work as early as I could. I want to be at work around 6:40 or 6:45 because I wanted to be there so that I will be able to take a look on my patient and the loads that I'm going to be assigned. So as soon as I get in there around 6:40, 6:45, I'm gonna go up and then take a look at my patient assignment. Usually we get 4, 5, max to 6 patients most of the time. And then as soon as I got those, I'm gonna log into our charting system. So we are using Epic. And then I'm gonna assign all those patients that was assigned to me. So if it's your first day of your 3 days in a row, I'm talking about it's kind of different on the second day. We do love the continuous flow. So if we have them on our first shift, for sure, if they're still at the hospital or if they're still inpatient, we're gonna have them for the rest of our shifts, on a week. Let's say this is my first day for my 312s. So I really like to read all, as much as I could, a little thorough, looked up about my patients, not all of them, because there's also the night shift nurses that are waiting for you so that they can leave. They wanted to do their bedside report so they can leave. So let's say I give myself because I arrived there 6:40, 6:45, I'll give myself for at least less than 10 minutes just to assign my patients through my Epic chart, and then basically just read all the diagnoses. What are they there for? I'm out of usrn. What are we diagnosing them? Just a little bit of run through. And then after I get that, I also prepare my brain sheet. Basically, I have a report sheet that I like to write down all the things that I get from the report from the previous nurse. So I will prepare that and I will show you guys how I use that, but that would probably be in a different vlog. As soon as I get all those things ready, now it's time for me to get the bedside report to the previous shift from the last night nurse. So typically I get it 10 minutes before 7, or it depends on how busy the nurses are. Maybe they're still stuck in the patient room. I'm just gonna wait for them until they're ready, and then basically I'm just gonna wait at the nurse's station until they call me. I also forgot that we also do a huddle, morning huddle with our this is so good, with our manager. Just talk about some things, important things that they wanna inform us, anything new, anything that needs to be taken care of, you know, stuff like that. We do our morning huddle. So after the morning huddle, then I'll wait for the nurse to give me the bedside report. When we talk about bedside report, it means you have to be there. You have to go to the patient's room to do or pass down the report, and you access it through your chart of the patient, so you can run through a little bit about, you know, while doing a report with the patient. Because I've already read about the patient, so I already know when they came in, unless if I didn't get that information. So I have to ask the nurse when is the admitted date. Basically just a run through, like for example, they came down at the ER, complaints of, and then they were moved to the ICU, they were intubated, extubated, and then they were moved to Medsurg. Like just a little run through. So as soon as we start the bedside report, I like to, I don't know what's my dog's issue right now. TJ's being grumpy, so I don't know what's his issue. Anyway, as soon as we start our bedside report, once the nurse starts to talk about my patient, I like to assess my patient's neuro. Like just a quick assessment with my patient. Basically, I want to know if they're still awake. Like I'm going to introduce myself, that I'm going to be taking over for the day, that I'm going to be his or her nurse throughout the day. I also like to assess the lines, drains, and airways. So basically, I want to just take a look while listening to the nurse. I think when I was a new nurse, like when I was during my orientation, it's really hard to receive a bedside report, and at the same time you're doing like an objective assessment. Basically, you're just looking around. I will take a look what lines or what IV fluids they are receiving, and if it's in a correct rate. And after that, I'm gonna take a look if she has any drains, let's say a wound vac, a chest tube, stuff like that, and a nasogastric or an NG tube. Also want to take a look if she is she's using a oxygen supplement, like what's the liter she's on, if she's using a BiPAP or a CPAP at night. You know, those were the things that I really like to know during the bedside report. So once I know those things, I will also ask the nurse, like, what are the trending labs of the patient. I want to know, let's say the patient received a blood transfusion, and I want to know if, you know, they already checked the H&H of the patient, and if I do need to do another unit of blood, you know, things like that. If the patient's potassium levels are low, are they receiving anything for that? I don't really ask a lot of questions during the bedside report. I only try to take a listen to what the nurses say, and I never interrupt them. I only ask them as soon as she's done talking about that patient. Those were the time that I would ask some, a few questions, but not a lot, because you could still, check it on the chart anyway. However, if it's a very important thing that you don't want to miss, especially if it's needed first thing in the morning that needed to be done, for example, they were not able to get the UA or the urine culture of that patient. So I just want to make sure if I needed to do that before I start my shift, or else I'm going to forget about it. Like, is there any pending labs that I needed to do, or I needed to look for it and inform, the physician. So once the bedside report is done, I'm gonna put this on my hair again. I have so many things. Oh, I think I did already, but I'm gonna put another one. As soon as I'm done with my bedside report with the nurse and with my patient, usually before I leave, my patient, I'm gonna tell them that I'll be back in like 30 minutes or so, and if they need anything. There are times that you will get patients that are not alert and oriented, so I just want to make sure if they are responsive through voice, or if I do a sternal rub and they would moan and grimace. So that's how I assess, if they're still doing okay. So we are gonna talk while I am cooking. That's what we're gonna do, guys. I'm gonna prepare something for dinner. So I'm gonna try and make a chicken curry. I'm not gonna dry my hair because I'm just gonna be at home. So basically I'm just gonna air dry it like this. Anyway, so when I'm done doing the bedside report with the patient, I'm gonna go back to the nurse's station actually, and it depends on what I'm gonna do. If it's my first shift of the week and I barely know all my patients, and if I felt like I needed to do a little bit of reading on their chart again prior to going back to my patient, I'm gonna check my patient's chart if I didn't get all the information that I needed from the previous nurse. I like to also read the notes, especially the HPI, because basically know everything on how did the patient ended up there. You're basically gonna know the summary of the patient. I like to review the new orders of the patient and the current orders of the patient, but specifically if there are anything new that I missed during the bedside report, I like to review them. I want to know the update vital signs, or what's the trending. Like, I want to make sure that their blood pressures are doing okay. If there are any changes from yesterday till today that I came in, I just want to know, so at least I am well prepared if something's gonna happen. Let's say patient's blood pressure was normal, yes, for a few days, and then suddenly last night they become very hypotensive. And if they are doing something, or if there are any medications that could cause to lower down their blood pressure or their heart rate, and I want to make sure that I should check those vital signs prior to giving those medications. You know what I mean? So I like to know those things. I also like to take a peek on my patients' medications. Like, what are the important medications that I really need to give to my patients, or new orders that I needed to give, or let's say antibiotics that I needed to hang. If they have anything like beta blockers, if they are taking any thyroid medications, I want to make sure that they have received it early in the morning before I start my shift. Usually the night shift nurses give that, but who knows, sometimes maybe they're not able to give it and they forgot to tell you. So I want to make sure if the patient received those. I also like to review the meds because I want to cluster the medications. So basically, if my medications are 8, 9, and 10, I want to give all the medications at 9 o'clock if I can. But let's say, it depends though. Let's say if the blood pressure is really high and I really needed to give them something to lower that blood pressure, then I would give that. Once I am done reviewing the patient's medication, I already have all the information I needed. So now it's time for me to do the assessment. If it's my first shift of 3/12s, I like to assess, or I like to check all the charting prior to going to my patient. But if this is your second shift in a week, I like to start differently. So let's say this is my Monday. So I already reviewed all the chart, all the things I needed in the chart. And then I'm gonna go prioritize which patient I'm going to see first. So I'm gonna start to the easiest patient, to the patient that needed a lot of care. You know what I mean? For example, if I have a patient that she is coherent, she's alert and oriented, cognitive wise they're doing fine, not in pain, no farther complaints, they're basically to for recovery, and then they're let's say the plan for today is to discharge that patient I want to go to see that patient first. I want to see if there are anything that they needed to be done. But you know what? In between, there are interruptions because, you know, there are times that, hey, your care tech or your patient, your PCT is going to call you that, hey, the vital signs of this patient is really high, or they are complaining with pain, or basically, let's say the chest tube was disconnected, you know, God forbid I don't want that to happen with me. So I would go to see my patients, like do a little quick assessment. You know, I would check patients' vital signs if they are ACHS or AccuCheck, like if they're diabetic and they're gonna check the patient's blood glucose. You could actually access that on the chart as you assess your patient. So let's say as you go into this patient, she's really easy, no further complaints. However, her blood sugar is really high as soon as you get to the patient and see her chart. So I want to make sure that as soon as the meal is already basically on the floor, I have to make sure that I will be able to give their insulin prior to, you know, moving to a different patient. So I just want to make sure during my assessment that I have my ducks in a row, you know what I mean? So basically, I'm going to take a listen to my patient. I'm going to take a listen to their lungs, if they're coughing, if they're in pain, if they have bowel movement or they're constipated, any complaints from head to toe. I also want to try to take a look at their skin if I could. Just, you know, a quick run through, you know, while you're talking to the patient, you're just going to take a look to the patient, assess their pulses, pedal pulses, you know, if they have, you know, bruises and stuff like that. I'm going to take a look and ask them what happened and make sure that the call lights are within the patient's reach and the bed alarm is on. So those were the things that I would like to do during my assessment. And then let's say I'm done with all my easy patients. I already know what are the medications they needed, that I needed to bring, or what are the PRN medications that I needed to bring when I go back and start passing my meds. So as soon as I go to my patient that is the hardest patient, let's say this patient is bed rest or bedridden or basically very dependent to you. You basically need somebody to help you if you want to check the skin of the patient, especially the coccyx area, because they're always laying down, and you want to make sure if they have a current pressure sore, you want to make sure if it didn't evolve or if it is taken care of properly, and you want to make sure what are the things that you needed to do on that pressure sore. Okay, let's say my assessment is done. I'm done with the assessment, and I'm gonna go back to the nurse's station because I'm gonna start passing my meds. So same thing, I'm gonna start with my easy patients. I can bring them the water that they needed if they don't have, prepare my insulin, and if the insulin is, or if the blood sugar is really high, I have to make sure that I inform the physician so they can adjust the dosage of the insulin. Oh, I forgot to tell you, as soon as I'm also doing my assessment, I like to chart as I go. Like if they're coughing, so that's the time that I can chart it, and if they are congested, also at the same time while I chart it, I'm gonna go through secure chat. I'm gonna tell the doctor, I will check their medications and they don't have anything that could help them expectorate their phlegm. So I'm gonna ask the doctor if they could give her or give the patient a cough medication, or if I could order it myself. And then let's say patients complaining with nasal dryness, I could ask the doctor if they could order for me a nasal spray for that patient, you know, stuff like that. And then I chart as I go. Anything abnormalities that I hear on their lungs, I chart it, and let's see if it's new or not new, you know what I mean? It's easier that way, so at least you will not get behind with your charting, because it's so busy at the Medsurg department. Like, it's very busy. When you try to pass your meds, that's the time you can assess the patient on how they're able to take their medication. And if they have any, you know, difficulty in swallowing, that's the time that you can order for a speech evaluation, or you can check if they have ordered it already, and if it's not, then you have to order some speech evaluation. At least you would know, especially if this patient is new. And also, guys, during my assessment, I also like to talk about the my goals for that patient. For example, if the patient is going to discharge on that day, I'm basically gonna tell them they are going back to which facility that they're going, and I'm gonna give them updates. When is the ride gonna pick them up, you know, stuff like that. I usually like to inform my patients so they would know what are the plans and goals for today, so at least they know what's going on. And I felt like that's the only time, or that's one of the things that you can build a relationship with your patient. So let's talk about interruptions. If you work at the hospital and if you're at the Medsurg department, there's a lot of interruptions and you'll never know what's gonna happen. Let's say something happened, like before I had a patient that she was really tachycardic. Well, she was having a bowel movement, and then suddenly her blood pressure also dropped. So that was one of my interruptions that we really need to, you know, get to her and do all the things we needed to do. So another interruptions is our family. So you are gonna expect, especially if you're in day shift, you're gonna expect that there's gonna be families that are with the patient within their rooms, and they are gonna ask you a lot of questions. It really sucks if you are not taking care of those patients for a while, and it's basically your first time taking care of them, because sometimes you just don't know the answer of the family's questions. I usually just tell them, you know, this is the first time I took care of your mom, and I want to make sure before giving you a wrong information, so I'm gonna take a look at their chart and see if I could find out an answer, and if not, I'm gonna go talk to the physician, or maybe have them talk to you, or maybe that would be a great question that you could ask the physician, you know, during their rounds. So aside from that, family at bedside, there are also family gonna call you for some updates. We do our care team to around 11 o'clock in the morning. So basically, this is the time that the physician's gonna give us some updates regarding the patient, if they are gonna be sent in to a nursing home facility, a skilled nursing facility, if they're going for a rehab, or if they're staying for a little longer, or are we moving them to a different facility or a bigger hospital because we just don't have the facility that the patient needed. So those were the time that I could get updates. So once I receive a call from a family and wanted an update, I will just tell them, you know what, we're about to get ready around 11 o'clock in the morning, and I'm gonna be knowing some few updates about your family, and then I'm gonna be needing your contact details so I can give you a call as soon as I can. And if I will not be able to call you, you are free to call me back. Let's say if I will not get back to you after lunchtime. So I usually do that. So at least, you know, I would still be able to give them some updates as much as I could, because updates are also very important to family, because what if they're gonna be discharged and those family leave 45 minutes away from the facility. So at least I would be able to tell them that, hey, your patient is discharging today. I want to know what time are you guys gonna be able to pick up, or if are you gonna be able to give the patient a ride. So at least we could plan ahead, and I could tell, you know, that, hey, patient's leaving, although ride will be in here in after 2 hours or so. So yeah, those were the interruptions. What else I'm gonna be able to talk about? So once we are done with the care team, and let's say I have already get all the updates of my patient, same thing, I'm just gonna basically continue the medications that I needed to pass for noontime, check the blood sugars, if they needed the insulin, if any, it's just like basically the same thing. And aside from that, that's the time that I can do my basic care with my patients. So sometimes also after get some care, after the care team, I would also know that, you know, patient might need some consult with social worker. Let's say I will tell the physician that patient doesn't patient is homeless and they needed a place to stay before discharging. So I'm gonna tell the doctor if they could place a social worker consult, so at least the social worker can take care of that. And if patient doesn't have any insurance and stuff like that, I could also place the social consult. Or, you know, maybe the doctor thinks that patient needs to be consulted with GI or surgery, then at least I would know and I could tell the patient, or I could update the family about it. All right, now it's, you know, noontime. You already passed your meds for noon. Let's say patients already have their insulin, they have their meal already. Those patients that needed a bath in the morning is already done and taken care of. You're done with your morning routine. So if you could get a lunch break, girl, do that. We usually have 30 minutes break. I feel like I shouldn't be doing this. There are times that I like to take my breaks on the desk while I'm charting, and that is the time when I wasn't able to manage my time well. But if you really need a break, especially if it's so chaotic and if your shift is chaotic, make sure you get that 30 minutes, girl. Like, your charting's not gonna run, it's still gonna be there. And then aside from that, if you sit on the nurse's station, you're not going to be able to enjoy your meal because there's still going to be interruptions, and secretary is going to call you that, hey, since, I mean, you just don't want to sit there and eat and, hey, I'm on my lunch break. It's not it. If you want your lunch break, go leave the nurse's station so at least you could have a peaceful, quiet lunch break. So don't do like what I'm doing most of the time, but now I am actually taking my 30-minute lunch break because I just have to, or else I'm not gonna be able to function well the whole day and I'm gonna be grumpy. So yeah, take that lunch break. It's just a 30-minute lunch break, and then once you're back from your lunch break, or once I'm back from my lunch break, I'm just gonna do my charting. If I miss anything that I needed to do, most of the wound dressing, I do that in the afternoon because I want to make sure, especially for patients that are very dependent, I want to make sure I am there while I'm doing the bath, because that's the time I can take a look on my patient's wound, take updated pictures, especially if it's your first day, first shift. I really like to take picture of those wounds and on my third shift for that week. I don't know, I'm just like that. I just want to make sure if there are any changes, just to keep the chart updated. Let's say if the patient's gonna be receiving their fourth dose or fourth bag of vancomycin the next day, and let's say you're off the next day, you're not coming back, make sure to tell the nurse on your bedside report that they're gonna be doing a bank trough prior to giving the next bag, because sometimes it's not gonna be ordered, so you gotta make sure the next nurse knows about it so it will be ordered. Because I had that issue before while I was so new, and I give myself a pat on the back because I did check the bank trough. I was looking for it prior to giving the next dose, and it was a good thing to do. And I've been trying to take a look on that before giving patient their next medication. After that, give your medications. If they have meds from 3, 4, 5, or just cluster all your meds, so it would be easier and you'll be able to manage your time well. Let's say 3 o'clock, you can start doing your care plan. But my trick right now is I write some care plan notes during the day. Just do a timestamp, like let's say 6:45, let's say 8 o'clock, patient complain of difficulty in breathing. I just write all the notes there in the chart. When I do my care plan around 3 o'clock, I'm just gonna fix it. Came in around this time, patients alert and oriented. However, around 3 p.m., patients very confused and combative, like stuff like that. At least you know how to write it down during the care plan. And I usually finish my care plan, especially let's say I have 6 patients, I usually finish it as around 6 o'clock. If I am not really able to manage my time, sometimes I'm still doing my care plan 6:30 in the evening, and I shouldn't be advising that to you because it's a lot of headache. I'd say around 4 o'clock, or while I'm doing my care plan, I like to prepare my report to my next nurse, or to the next nurse, or to the night shift nurse. So I like to write down what I needed to talk about with the next shift. It's really easy if the nurse that gave your report to is coming back, because you're basically just gonna give them updates. It's, you know, really nice to do that, but it's not gonna be always like that. Basically, sometimes they're not coming back, so you have to give them the full report, which just sucks. But you know, you will learn, because I learn as I go. I used to be so anxious giving bedside report, but now I'm not that perfectionist anymore, because I know what to talk to, and I'm gonna talk to you guys about that the next time. You know, let's say I am done with preparing for my bedside report. So usually we're gonna start our report, let's say 10 minutes before 7 o'clock in the evening, or let's say 7 sharp. So I'm gonna go with the nurse and just give them time to prepare. Yeah, give them time to prepare. And then if that nurse only have one of my patient, I try to get them first as much as I could, so at least I could give them that one patient, or do the report of that one patient before they go to the nurse that have all their patients, because you're gonna wait. It's gonna be a long wait. So basically I'm just gonna ask them, hey, I have one for you, do you want to start now? So I'm just gonna give it to them, especially if it's just only updates. So I like to grab them as soon as I can, so we can leave early too. Like, who wants to stay there longer? Nobody wants to stay there longer after a chaotic shift. So yeah. And then same thing, we're gonna do the bedside report at the patient's bedside. And I want to make sure before I leave that their call light is still with them. I also want to make sure that their bed alarm is on, and you know, talk to the nurse, anything updates or anything that I wasn't able to do. For example, you had a chaotic shift and you were not able to do the dressing of that patient because of the situation that you were in during the day. So there's no problem if you're not going to be able to do that, because nursing care is a continuous care. It doesn't mean that it's not gonna be done. It's gonna be done through the next shift. The most important thing that you're gonna do is you tell the next nurse that you missed that care because of this. Because mostly nurses, we do understand that we cannot do everything, you know, on that day. But you just have to tell, you know, your next nurse. And then once I'm done doing my bedside report, we will chart that we did the report, basically put the nurse's name that are receiving your report, and then bam, usually 7:30 I'm gonna leave. I'm gonna be out of here, and I'm gonna tell the nurse that I'll be back the next day, or I'm not coming back the next day, so at least they could prepare also for their report for the next shifters. Anyway, I hope you enjoy this vlog, guys. I know it's a bunch of talking, but hopefully you learned something from me. And if you have any questions, just let me know and I will surely answer that if I could. So I'm gonna continue cooking.